If you've been researching full arch dental implants, almost everything you found has one thing in common. It tells you what you're getting, it almost never tells you what you're losing. And what you're losing is something you can never truly get back. You're probably somewhere in that research spiral right now. You've watched the videos, you may have even sat in a consultation or two. Everyone talks about the new smile, yet nobody has sat down with you and explained what gets taken away from you in order to build their kind of new smile. And nobody has explained why that decision follows you for the rest of your life. You've been shown the finish line, yet nobody shows you the true trade-offs. After treating thousands of full arch dental implant patients and spending years training other surgeons on how to do this procedure, I started seeing a pattern in revision cases. Patients who came to me after implants were done somewhere else, and what I found changed how I operate. But what I didn't expect was the thing causing the worst long-term outcomes wasn't a surgical error. The implants were placed correctly, the smile looked good. The problem was something that happened before the first implant ever went in. And it's something most patients have no idea to ask about. I'm going to walk you through what the standard approach actually does to your bone, why surgeons do it that way even when they don't have to, and what a different philosophy produces for the patient over the long run. Point 1, the bone you lose on day of surgery is gone forever. Most patients going into full arch dental implant surgery believe the goal is simple. Get the bad teeth out, put the implants in, and walk out with a new smile. And that's what the consultation focused on, and that's what the brochure showed. The assumption is that the surgeon's job is to make room for the new hardware and build the best looking result. This belief isn't wrong exactly. It came from dentists and the way the procedure has been marketed for years. The focus is always on the outcome, the smile reveal. That's an exciting time. The new you. Nobody in that room is drawing your attention to what gets removed in the process, because for most practices, that removal is just their standard way the procedure is done. Here's what's happening inside your mouth during that surgery that most patients don't know about. To attach a dental bridge of teeth to the implant in the bone, the bridge needs space to sit. The traditional material had to be thick enough to hold up to chewing and stay in place long term. The most common way surgeons create that space is by shaving down the bone ridge before placing the implants. They literally remove healthy bone to make room for a thicker prosthetic. That bone is gone. It does not grow back. You go in to get a better mouth, you leave with less jaw than you had when you arrived. The bone you're protecting is more than structural support for your implants. It is the foundation of your face. Your jawbone is what keeps the shape of your lower face intact as you age. When you lose significant bone volume, especially from the ridge where your teeth used to sit, the face starts to change. The cheeks lose their underlying support. The chin to lip relationship shifts. Patients who lose a lot of bone in this surgery sometimes describe it years later as looking older, even with a beautiful new smile. That is not a small thing. Bone loss is not a side effect to accept. It is something to minimize from the first cut. And here's what makes this stranger than it sounds. The surgeons removing the most bone aren't doing it because they have to. They're doing it because of something that has nothing to do with your anatomy. Point 2, surgeons reduce bone because the system rewards the bridge, not the patient. If you've been in a consultation, you've probably heard about different bridge options. You might have heard about zirconia bridges, titanium bars, acrylic, resins, and different attachment styles. Most patients assume the surgeon is choosing based on what's best for their specific anatomy. The bridge design, the story goes, is matched to you. But the reality of how full arch surgery is planned at most practices has less to do with your anatomy and more to do with the prosthetic the practice has been accustomed to using. Most surgical groups pick a bridge style and a workflow and they use it across all patients. The surgery is then performed to accommodate that prosthetic. In other words, the bone removal is not planned around protecting you, it's planned around a quick bridge design. When the prosthetic material is driving the surgical plan instead of your anatomy, the patient's bone becomes a variable that gets adjusted. Too much natural bone height? Shave it down. The old prosthetic needs a certain clearance to be strong enough. Remove what's in the way. Most patients don't know they could have kept that bone. The plan wasn't built around your jaw, instead your jaw gets shaped around the plan. And here's what makes this harder to solve than it sounds. The standard approach has real logic behind it. If you don't understand that logic, you won't know how to push back on or recognize when a surgeon is doing something different, because a different approach does exist, and that requires something most high volume practices aren't willing to do. If this is landing for you and you want to go deeper on how to actually evaluate a surgeon before you commit to anything, I've got a lot more on this channel. Hit subscribe so you don't miss the videos on what questions to ask, what red flags to look for, and what the full arch process should actually look like when it's done with the patient's long-term health as the priority. Point 3, how to tell if your consultation is actually built around your bone. You've probably been in a consultation that felt thorough. Imaging was reviewed, options were presented, a treatment plan was put in front of you with a price and a timeline. Most patients leave that appointment feeling like they've been assessed. What they don't know is that there's a specific set of signals that tell you whether bone protection is actually part of that plan or whether it was never part of the conversation. The way a surgeon talks about your bone in the planning phase tells you everything about the philosophy driving your surgery. Not the implant count, not the material options, the bone conversation. If it happened in detail, you're in good hands. If it didn't happen at all, it's time to reevaluate. Here are the questions. Did your surgeon explain specifically how much bone they plan to remove and why that amount is determined by your anatomy rather than the prosthetic design? Were you shown a 3D digital planning model of your bone volume before the bridge options were presented? Or did the bridge options come up first? Did anyone walk you through what your bone structure looks like 5 and 10 years after surgery compared to today? If the answer to all three is no, the planning conversation wasn't complete. That doesn't mean the surgeon can't do good work. It means you haven't seen the full picture yet. Go back and ask those questions directly. A surgeon who has thought hard about bone protection will have clear answers and a planning model to show you. If the answers are vague, that tells you something very important. Once you understand what's driving the standard approach, the question becomes whether there's a way around it. There is, and I'm going to share it with you now. Point 4. There is a way to do this surgery that protects your bone. Most patients never know to ask for it. If so much bone is lost because of thick bridges, why doesn't someone design a thinner bridge? We actually do have thinner bridges, and a thinner bridge requires less bone removal. It's engineered to sit closer to the tissue with less bulk underneath it. It can be supported by implants that sit deeper in the jaw, which means the surgeon does not need to level the bone ridge as aggressively to create clearance. Less clearance needed means less bone taken. The bone that stays is the bone your face is built on for the rest of your life. So why don't all practices do this? Because it's harder. A thinner bridge takes more time to plan. It's more difficult to make it look naturally beautiful and more difficult to be strong enough. Yet I promise you it is possible. The bulk underneath a standard bridge is doing the work. It removes and replaces the bone and natural gums with fake prosthetic gums, creating the illusion of a full smile rather than keeping the natural gums and replacing only what is necessary, the bad teeth. When you sit the bridge closer to the natural gum tissue, the cosmetic challenges go up. It requires more precise planning, more custom design work, and a workflow built around each patient's specific anatomy. When I train other surgeons on this approach, the pushback is almost never it can't be done. It's that it takes longer to plan. That planning step gets skipped when volume is the priority. The patient pays for that permanently. What I want for you is to stop assuming the bridge design in your treatment plan is fixed and non-negotiable. It is a planning variable. If nobody has explained the relationship between the bridge design and the amount of bone being removed, you have not had the full planning conversation. Ask your surgeon to show you the 3D planning model and walk you through how the bridge design was matched to your specific bone. The planning starts with a CT scan and a full facial analysis layered together into a single digital model. The new smile gets designed first. The implant positions get worked out to support it. Then and only then does the surgeon determine what bone reduction is actually required. Patient's anatomy first, tooth design second, and then customize the prosthetic to the patient's real anatomy. If the surgeon you're sitting in front of can show you that sequence in a planning model, you are in the right place. If they can't, you know what to ask for. Knowing what to look for is one thing. Walking into a consultation ready to act on it is another. Point 5, what to do before your next consultation. The bone you walk out with on surgery day is the bone you carry with you for the rest of your life. Implants can be revised. Bridges can be replaced. Bone and gum tissue does not regenerate to its original volume once it has been reduced. Protecting it on the day of surgery is not a minor consideration. It is the most permanent decision made during the entire procedure, and most patients don't even know it's a decision at all. When you walk into a consultation understanding this, you are not a passive patient hoping to be told the right answer. You are someone who knows what questions to ask, which means you will get very different answers than someone who doesn't. And those different answers may lead you to a very different surgical plan. Here's exactly what to do before your next consultation. Pull up the 3D imaging you've already had done, or confirm that the consultation you book will include a cone beam CT scan at that appointment. Do not proceed with a surgical plan that is based on a two-dimensional X-ray. Write down these 3 questions and bring them with you. How much bone do you plan to remove, and why is that amount specific to my anatomy? How is the prosthetic design being matched to my bone structure rather than the reverse? What does my bone volume look like 10 years after the surgery is completed? If the practice cannot show you a 3D digital planning model before surgery is scheduled, ask why and what they're using instead. The answer will tell you whether the planning is custom or templated. Look up whether the surgeon performing your case has training in bone protective or minimally invasive full arch dental implant techniques. This is not standard. Not every practitioner who places implants has trained specifically in bone preservation. Ask directly. If you've already had a consultation and those questions weren't answered, you have not yet had enough information to make a final decision. Go back, ask. The surgeon who is doing this right will have clear answers to all of those questions. Full arch implants can be genuinely life-changing. I've seen it 1,000 times in my patients. But the result that changes your life isn't just about the smile you see on day 1. It includes the jawbone you leave with and the bone you will have 20 years later. The surgeon who talks about your bone as carefully as they talk about your smile is the one worth sitting in front of. If this gave you a new way to think about this decision, be sure to check out this video that goes over how I think about every new patient to make sure they're getting exactly the right treatment they need, whether that's surgery or not. It's popping up now. Go ahead and click.